Bismillah ar-Rahman ar-Rahim. We will talk today about nocturnal enuresis in children. It is a very common problem in children. About 15% of children by the age of 5 years are incompletely continent of urine. Most of these children have isolated nocturnal enuresis, what's called monosymptomatic nocturnal enuresis, and we will discuss the monosymptomatic nocturnal enuresis briefly after. Enuresis, by definition, it is a separate episodes of urinary incontinence during sleep in children more than or equal 5 years of age. It is divided into monosymptomatic and non-monosymptomatic forms. First, monosymptomatic enuresis. By definition, it is enuresis which occurs in children without any history or symptoms of other lower urinary tract or bladder dysfunction. It is divided into primary and secondary forms. Primary enuresis, it is enuresis which is monosymptomatic without any other symptoms of lower urinary tract or bladder dysfunction in children who never achieved a satisfactory period of nighttime dryness, and it is about 80% of the children with nocturnal enuresis. While secondary enuresis occurs in children who develop enuresis after a dry period or satisfactory period of nighttime dryness of at least 6 months. Usually, it occurs secondary to a stressful event occurred to the child as caregiver divorce or birth of a sibling, but the exact cause of secondary enuresis remain unknown. About non-monosymptomatic enuresis, it is enuresis in children with other lower urinary tract symptoms, including either increased more than 8 times per day or decreased less than 3 times per day voiding frequency. This means that the normal voiding frequency ranging from 3 to 8 times per day in children. Also, it's accompanied with daytime symptoms, either incontinence or urgency, weak stream, or intermittency, which is a micturition occur in several spurts, hesitancy, which is difficult to initiate voiding, straining by application of abdominal pressure to initiate and maintain voiding. Also, if there is a post-micturition dribble or feeling of incomplete emptying after voiding, it's also a symptom of bladder dysfunction or lower urinary tract symptoms. And finally, genital or lower urinary tract pain also it is abnormal. Patients with nocturnal enuresis with daytime symptoms like incontinence or urgency are described as having what's called bladder dysfunction, which is also called complex or complicated enuresis. Bladder dysfunction is either due to urological or neurological disorder. Urological disorder like detrusor, which is muscles of bladder, detrusor instability or recurrent urinary tract infection, or neurological disorders like spinal dysraphism or spina bifida. And the children who are associated with urinary and bladder symptoms together are described as having bowel bladder dysfunction. About monosymptomatic nocturnal enuresis. It occurs twice common among boys versus girls, and it resolves spontaneously at a rate of approximately 15% per year. But the longer the enuresis persists, it means the lower probability that it will spontaneously resolve. What is very important is to know about the normal bladder function, which depends upon complex coordination between autonomic and somatic nerves. This complex coordination permits urine storage and also voiding. Urine storage at a low pressure with high outlet resistance, while voiding occurs with low outlet resistance and sustained detrusal muscle contraction. Bladder capacity. Normally at birth, the bladder volume is approximately 60 milli, and it increases with age at a rate of approximately 30 milli per year until 10 years of age. This means that expected bladder capacity in milli normally equal 30 multiplied in age in years plus 2. At birth, voiding is efficient but uncontrolled, and it is also can be initiated by other neurologically stimulating activities such as suckling and bathing. By 4 years, the child at least during the day, first become aware of bladder filling and ask to go to toilet. Then it developed the ability to suppress detrusal contraction voluntarily. And finally, it learned well to coordinate between sphincter and detrusal function so he can resist the urgency to go to void. While nighttime bladder control is achieved months or years after daytime control of voiding, but it is not expected until 5 to 7 years of age. Pathogenesis of monosymptomatic nocturnal enuresis can result from one or a combination of several factors, including first, maturation delay, which is delayed maturation of normal developmental process, and it is the most common accepted factor in pathogenesis of nocturnal enuresis. And it's proved that in almost all cases of nocturnal enuresis, it is resolved spontaneously. Second, genetic factors, by evidence, the occurrence of nocturnal enuresis among monozygotic twins is almost twice that occurs among dizygotic twins. And also, when one parent gave a history that he was incontinent, about 50% of his offspring are affected, while if both parents have that history, about 75% of offsprings are affected with nocturnal enuresis. Nocturnal polyuria, by definition, it is increased the nocturnal urine output more than 130% of expected bladder capacity for age. And although it doesn't explain why the child don't walk to void. And the mechanism for nocturnal polyuria included increased fluid intake before bedtime, after evening time, and reduced response to antidiuretic hormone and or decreased the secretion of antidiuretic hormone. Disturbed sleep, as most parents often describe their children with nocturnal enuresis as deep sleepers. But it is controversial, as many of sleep studies found that children with refractory nocturnal enuresis, which is by definition more than or equal 5 wet nights per week, sleep more lightly than control, but it didn't walk before voiding. Small bladder capacity, and which is mostly functional rather than anatomical, and detrusal overactivity, which are more frequently associated with daytime urinary incontinence rather than nocturnal incontinence, but it should be considered in children with refractory monosymptomatic nocturnal enuresis as a defect in a circadian rhythm of detrusal inhibition and or pelvic floor activity. And lastly, psychological and behavioral abnormality, which appears to be a result rather than a cause for nocturnal enuresis, as it tends to improve after resolution of the problem. How to evaluate a child with monosymptomatic nocturnal enuresis? This evaluation should include history, physical examination, and urine analysis. The history should include what's called voiding diary, which is a mainstay of the evaluation. This voiding diary includes timing of daytime voids, which is very important, and what is extremely important is the volume of voided urine to estimate the bladder capacity and is it normal or abnormal for the age. History. History. Many historical features are important to be taken when dealing with a child with monosymptomatic nocturnal enuresis. First, the presence or absence of daytime symptoms or lower urinary tract symptoms for possible significance of presence of dysfunctional voiding or anatomic abnormalities as post-urethral valve. Prolonged period of dryness to differentiate between primary and secondary enuresis, frequency of episodes, changes in the frequency of episodes over time, and approximate volume of enuretic void to estimate also bladder capacity, and the fluid intake diary to exclude the presence of nocturnal polyuria, stooling history to confirm or exclude constipation, which contribute to decreased bladder capacity, and the review of other systems as presence of snoring, which suggests the presence of obstructive sleep apnea, weight loss and fatigue in diabetes and the chronic kidney disease, gait abnormalities with spinal dysraphism, spills, and presence of pinworm infestation when giving a history of vulvovaginitis, excessive thirst and nighttime drinking, suspecting diabetes, chronic kidney disease, or psychogenic polydipsia, and the presence or absence of a positive family history of enuresis as genetic factors may be contributing. About the physical examination, presence of bowel growth and hypertension signify presence of a chronic renal disease. Wetness in the underwears give an idea about the presence of daytime incontinence. Palpation of stool in abdomen confirming that the child is constipating. Also presence of vulvovaginitis give an idea of presence of pinworms infestation. Abnormalities in lumbosacral spine is very important to examine the back of the child, and incomplete bladder emptying and observation of slow urinary streams or straining or dribbling or intermittent stream give an idea of urological abnormality, and abnormal neurological examination of the perineum and lower extremities also signify presence of any spinal cord abnormalities. Urine analysis should be performed in all children with nocturnal enuresis. Urine analysis including specific gravity is obtained as a screen for DKA, diabetic ketoacidosis or diabetes insipidus or water intoxication, and for urinary tract infection. And it should be performed on the first morning void. And urine culture is not necessary unless indicated by presence of white blood cells or positive nitrite test on urine analysis. Imaging is not a routine for any child with monosymptomatic nocturnal enuresis, and it is included urological and neurological imaging. Urological imaging as renal ultrasonography and voiding cystourethrogram, it obtained in children with significant daytime complaint and a history of recurrent UTI, history of UTI not previously evaluated, and or signs and symptoms of structural urological abnormalities as posterior urethral valve. Sonography also helpful in determining the post-voidal residual volume and bladder wall thickness. While neurological imaging, usually MRI spine, is asked for children with lower lumbosacral spine abnormalities. Management of monosymptomatic nocturnal enuresis, the age is problematic, as it depends on the problem magnitude for both child and his parents, and it varies from family to family. And it is important to determine whether the child is mature enough to cooperate and highly motivated to participate in treatment program. In children younger than 6 years, only educational and motivational therapy is required. But for older children, we offer treatment whether or not they or their caregivers have considered enuresis as a problem, after we have excluded the secondary causes of enuresis like constipation or presence of diabetes. Educational and motivational therapy. It is the initial step for management of enuresis, and it includes the following points. We should educate the child and his parents that enuresis is common. It occurs at least once per week in approximately 15% of 5 years old children, and it resolves on its own in the majority of children. Neither the child or his parents are at fault for enuresis. Children should not be punished for bedwetting. Keeping a calendar for wet and dry nights helps to determine the effect of intervention, and it is very important. And the child should advise to void a total of 4 to 7 times per day, including just before going to bed. And if the child walks at night, the caregiver should take the child to the toilet to void again. High sugar and caffeine-based drinks should be avoided in children with enuresis, but particularly in the evening hours. I think it increases the nocturnal polyuria. And restricting fluid intake in the evening may be helpful for some children, but should be continued only if it is successful. And the routine use of diaper should be prohibited. As it can interfere with motivation for getting up at night, and initial rewards should be given for agreed upon behavior, like going to the toilet before bedtime rather than dryness, while successfully larger rewards agreed upon in advance are given for a longer period of dryness. Initial active therapies. It usually include enuresis alarm and desmopressin synthetic vasopressin analog. It is a form of antidiuretic hormone. It should be considered for children with monosymptomatic nocturnal enuresis who have no improvement after 3 to 6 months trial with initial management, educational, and motivational therapy, and if enuresis continue to be a problem for the child and family. For children who have enuresis more than twice per week, this is very important, enuresis more than twice per week, and short time improvement is not a priority for the child and his family, we suggest enuresis alarm. So, high frequency more than twice per week and short-term improvement is not a priority, I should consider enuresis alarm, as it has also a lower relapse rates. While in children who short-term improvement is a priority and who have a nocturnal polyuria with normal daytime voiding volume or who have enuresis less than 2 times per week, we suggest desmopressin, as it more rapidly effective than alarm, but it has a higher relapse rate. Enuresis alarm, simply it consists of 2 parts, sensor and arousal device. Sensor placed in the undergarments or underwears or on a bed to detect moisture or wetting, and followed by sending signals to the arousal device, which is usually auditory or vibratory pager. The treatment with enuresis alarm should be continued for at least 3 months. At least 3 months. If the child demonstrates early signs of response, smaller with patches, walking to alarm going off later in the night, fewer alarm per night, fewer wet nights. Alarm treatment should be continued until the child has had at least 14 consecutive dry nights, 2 weeks of dry nights. And therapy with alarm can be reinitiated for a relapse if the child starts to suffer again for more than 2 wet nights per month. After a 3-month trial, alarm therapy should be continued if the child has more dry nights per week than at baseline, even if they have not achieved the 2 weeks of dry nights. Failure to demonstrate early signs response for enuresis alarm, I should add a low dose desmopressin to alarm therapy or discontinuation of the enuresis alarm with a plan for subsequent trial 6 to 12 months later when the child is become more mature. About desmopressin, it is orally administered 60 minutes before Pediatric. And the most serious adverse effect is a dilutional hyponatremia, which occurs when the child drinks an excess fluid after he takes his dose or in evening hours. The initial dose and titration vary with the formulation. We have two formulations for desmopressin. Regular tablet, the initial dose is 0.2 milligram. If necessary, it can be increased up to 0.4 milligram after 7 days. Or oral melt tablet, with another way for manufacturing the desmopressin. The initial dose is 120 microgram. If necessary, can be increased to 240 microgram after 7 days. The response should be assessed within 1 to 2 weeks. And the treatment should be continued for 3 months if there is a signs for improvement or signs of a response. And when discontinuing daily desmopressins, the dose should be tapered, providing one half of the effective dose daily for 2 weeks before discontinuation, rather than discontinuation abruptly or exceeding the interval between doses. For refractory enuresis, which by definition, if there is no response to an adequate trial of treatment with an enuresis alarm for 3 months or desmopressin at a dose of 0.4 or 240 microgram for melt tablet, 2 for 2 weeks, or for combinations of alarm and desmopressin. And here, referral to specialist should be considered. And further evaluation to exclude other causes of enuresis should be done. And about management of refractory monosymptomatic nocturnal enuresis, we have multiple drugs can be used, like tricyclic antidepressant imipramine, which stimulates vasopressin secretion and relax of the detrusal muscle, bladder training or retention control training by asking the child to hold his urine multiple times per day for successful longer intervals to increase the bladder capacity, or giving anticholinergic drugs like oxybutynin in combination with desmopressin to increase the bladder capacity during sleep, or electrical stimulation therapy or neurostimulation, which done by implantation of non-invasive devices that stimulate the pelvic muscle contraction and modulate the detrusal contraction. And thank you, hoping that the message was delivered to you easy and successful. Thank you.